Schizophrenia Society.
Okay, thank you. I have to put this down a little bit. Can you hear me? I probably don't even need a mic. I happen to be the co-chair of the Mental Health Coalition of Nova Scotia, and we're very pleased to host the second time Visiting Professorship in Medical Citizenship. For those of you who don't know, the Coalition is a nonpartisan group of concerned individuals and many different organizations, mostly non-profit organizations.
Yeah, yes.
Okay. Okay, our mission is to raise the priority of mental health issues on the government agenda and address the chronic underfunding of services. Welcome, and thank you for joining us in person, or we also have this via webcast. So if how many do we have online?
No one.
Oh, no, yeah, okay. Should have asked. We would like to thank the sponsor of today's event, Department of Bioethics, Dalhousie University. And I meant to ask Dr. Delva earlier, is this just the second year that you've been doing this, that Dell has been putting on medical citizenship, or?
It goes a number of years.
Oh, does it? Okay, it's the second year we've been involved. Pardon?
We have two on that. We have two on
Oh, we have two on there. Hi there. The annual Visiting Professorship in Medical Citizenship provides an opportunity to discuss a number of underlying issues that affect the healthcare system. Medical citizenship means that physicians should use their voice and be free to speak out on health issues that need to be addressed without fear of repercussions. I would also add that I think it's the responsibility to be speaking out. I'm going to ask Dr. Nick Delva to introduce our guest speaker. And Dr. Delva is the head of the Department of Psychiatry, Dalhousie, and Dalhousie University, and chief of the Department of Psychiatry, Capital Health. Dr. Delva's clinical work has been in general adult psychiatry, particularly focused on the care of patients with mood disorders or schizophrenia. Dr. Delva? And Dr. Delva is going to be our panel moderator also.
Thanks very much, Donna. It's my pleasure to introduce our visiting speaker, Dr. Turnbull, who I've known for a number of years, and I'm also just going to introduce briefly the other members of the panel. Dr. Turnbull is a quintessential example of medical citizenship in action. His career as being as a leader in clinical medicine. He's had a number of academic and administrative positions. He's been innovative in terms of developing services for underprivileged and underserved groups. And we're going to hear about his work in a few minutes. He's an exceptional person, and his work is being recognized. He's being recognized in a number of ways, including as a member of the Order of Canada. So we're very happy to have him here today, and I think we're very fortunate. To his left is Steve DeVoe, who is a support worker here in Capital Health and with the Self-Help Connection. To his left is Cindy McKaiser, who works just down the street, who is working at Section 180, the maintenance program. And to her left is my colleague in the Department of Psychiatry, Dr. Philip Mills, who's the clinical academic leader for addictions in Capital Health mental health and addictions program. So with those brief introductions, I'd like to welcome Dr. Turnbull to give her presentation.
It's great to be here. Just figure out how we do this. Let me forget that, and I can see the. So what I wanted to do today was to, first of all, thank you very much for coming and listening. So and allow me to present a perspective I bring as it relates to issues of mental health and addiction. But mine, I said. Better? Thank you. You hear in the back?
Yeah.
All right. So I'll speak more directly, though, about my unique population, because to be perfectly honest, I'll declare my confidence right at the beginning. I'm a specialist in internal medicine, and my domain is within impoverished communities, so I work with the homeless in the city of Ottawa. And so I don't have a great deal of experience beyond that. To be honest with you, from the mental health perspective and addiction perspective, I've been drawn into that inadvertently, not kicking and screaming, but in trying to recognize the needs of our community. I've had to become somebody who is an advocate in that area and somebody who can gather out and get the necessary resources in terms of mental health and addiction. What we did was to begin to try and think about what the needs of that community would be. And I'm going to try, if I can, to explain to you what addressing the issue of mental health and addiction through an equity lens would look like. So trying to provide equitable care to people who live in very challenging circumstances. And those are my clients. So this is what the high cost, high risk populations are referred to, and I don't really like that terminology. You've probably all heard about this. This is a population that I see very frequently. These are people who would be people who would constitute the 5% of our population who utilize is about 40 to 6% of all total healthcare resources. And this population would be people who have been referred to as frequent users. And I have to say those kind of people have high needs and don't get very effective care. And that's the problem. It's not the fact that they have high needs, it's to provide appropriate care for them. So who are they? They lack effective care and entitlements. They don't get the same access to resources that you or I in the housed population would normally expect. Not only that, the care that they do get is fragmented, it's crisis-driven, often inappropriate, and without a sense of continuity. They live in circumstances where they're vulnerable, they're isolated, they lack personal resilience, that sense of family or support system around them. They're voiceless, and they seem, in my setting, almost universally joined by one common thread, and that's their poor. So that's the type, I just wanted to set the stage and say, these are the types of patients that I deal with on a regular basis. So let's go on. And maybe I could just highlight for you that, that this is not just an isolated problem, but it's a problem that is growing in perspective. And I want to just really highlight to you that social inequity that affects so many people is growing in Canada. Matter of fact, it's growing in most other developed countries more fast than other settings. And it's leading to significant impacts on those people who are most disadvantaged. And if we were investing more into social services for that population as they grew in size, it would be bad, but not as bad. But the thing is, we're not. As we've seen our lowest socioeconomic grow, our poverty grow in Canada proportionately, we've actually restricted or reduced the amount of services that they get. So we have a larger population, greater need, less services. And that's been a trend that's been happening over the last 5 to 10 years in Canada. So greater social inequity, less resources, and the consequence being greater health inequity. And it plays out dramatically as it relates to the individuals, their overall life expectancy, and the quality of their life that they experience. So let me just highlight a few points before I talk to you about the lens that I would like to think about as we look at health equity in that context and what I've learned about that. But first, let me tell you, within Canada, within Nova Scotia, I would imagine that there are pockets of your population that experience inequity that is so severe that the effect on your health is very comparable to where I work in rural Bangladesh or sub-Saharan Africa. You might think, oh, I can't believe that. But the drive from the richest part of Hamilton to the lowest part of the poorest part of Hamilton is about 10 minutes. Life expectancy drops 21 years. The likelihood of living to the age of 75 in one of my shelters is 25%. The likelihood of getting tuberculosis on our reserves is higher than where I work in rural Bangladesh. HIV rates in my injection drug users higher than sub-Saharan Africa. Hep C rates in injection drug users, 80%. Epidemic. So, major health inequities within populations of great affluence, and generally a healthy population. You know, we have our challenges, but within that context, we see pockets or isolated groups who suffer dramatically because of health inequity. So, let me get, what would you do then if you knew that and wanted to address the problem? Because access to health services is pretty good, by and large, for people who don't need it that much. So you're wealthy, you've got lots of family around you, and you've got lots of support. Yes, you're going to wait a little bit longer you're going to have to wait 8 months for a total knee joint replacement. My patients will never get on a list to get their knees replaced. This will not happen if you're homeless. So there's polar differences in the expectations that we have of our health compared to the housed versus non-housed population of homeless. So if we were to look at that, I'm going to describe my population in just a moment, but looking at the lens of equity means, first of all, you have to know your community involved. So how many people do we know within your district or region? Where are your homeless? Where are you most vulnerable? Well, I would imagine, like us, we don't really know. For example, when I went to look at injection drug overdoses, ambulance and fire 911 visits by our ambulance services for overdoses, the incidence in the Champlain region was the same as it was anywhere else in the Lynn and in the province, and they said we don't have a problem. It's kind of strange to me because I'm aware of 4 overdose deaths within the last year. And so we mapped it out by, not only by block, but by building, because we had the ambulance addresses of all the ambulance and police calls. It all occurred within the space of 2 blocks. All deaths, all overdoses within 2 blocks. It was epidemic in that area. I could actually tell you the buildings that they occurred in. So we had something that was epidemic for that area, overdose deaths. Yet we didn't even know about it, because we thought we were the same as everybody else, and there was no challenge. And Lynn-wide, perhaps we don't have a challenge, but those people in that district, those individuals, certainly had a problem. So you need to know who you're dealing with. You have to consider the barriers based to access, and I'm going to talk about that a little bit. So what were some of those barriers that they experienced that directly affect their ability to get access to services? And I had all my thoughts about that, none of which were correct. We actually went down and sat with them through focus groups and meeting with the individuals involved. They said, no, that's not a barrier. Here's my barrier. And that made it much more relevant. And then we had to engage all of the communities, we had to get everybody on side, we had to get those involved, yes, but all the providers, all the services, all the community groups, everybody had to be on the same page. And then you had to try and mitigate social factors. Dealing with the mental health and addiction, that was, that's hard enough. But really can't deal with that until you actually deal with the challenges that they face around the housing, the poverty, the lack of education, all of those social determinants, which we know are so important. Unless you get them into a stable environment with that regard, and you deal with nutrition and all of their other concerns, it's going to be preciously difficult to deal with their mental health addiction. Getting them into a stable, supportive housing environment is key. I'm not telling you guys anything I suspect that you haven't heard. And then we had to start to work with different partners that we were never used to dealing with. So I deal now more with the criminal justice system than I do with the hospital. I deal more with judges, police officers, housing officials, social workers than I've ever done before. New partners, that's kind of fun, but pulled away more from what I would have thought I was going down there to do, is just treat some arthritis and tuberculosis and a foot infection here or there, and that will be fine. It's a whole new, different ball of wax. And then you better know you're making a difference. You better have metrics that are reasonable to demonstrate evidence. So I'll go quickly now through the challenge of context. So if we go through, we're no different than you, I suspect. We've got about 1,000 people who are homeless every night. Understanding on a population per capita basis, that would be that different from here. But we've seen a dramatic change, probably like you. So we used to have, 15 years ago when I started this business, it was the adult male alcoholic. And now we've got youth, families, elderly, immigrants. We have a whole mixed group, and we don't have just alcohol now. We've been honored with crack cocaine and heroin and crystal meth. And so it's a challenge to try and deal with the vast variety of different addictions that we face on a regular basis. And we got as well the associated challenges that have kept up with that comes in industry use, the sex trade, we have HIV, Hep C rates, as I told you about. So this is our adult population, but most men, some now a growing number of women. We find many people out around us, not just in shelters, but in room houses and unstable houses. We'll go through quickly these. We have youth now. They're coming up the valley. They're often fleeing from circumstances of abuse up the valley in Pembroke or Arnpright. They come down. And if you've got a 15-year-old coming into a shelter environment, you've got to get to them within about 6 months before they become ingrained in the culture there. They'll be addicted very quickly. They'll be involved in the sex trade, and then they're going to have HIV, Hep C, and the next thing you know, they're not going back to school in Pembroke. So there has to be an early intervention for the group. We have families, I expect like you, early interventions for this group with a family intact. They just need housing, supportive housing, subsidized housing. Our wait is 5 years. So that is not going to happen easily. That child is probably going to go to school like some of our other children. They're going to go directly to school from an adult male shelter. That's no way to raise a child, I can tell you. We have women, of course. Many of them are involved in the sex trade. Many of them have mental health issues, of course, and addictions. And they also have had children, frequent encounters with the child welfare system. And then the mental. Now for us, in our population, the homeless population, mental health issues vary depending on how we report it and how we try and sort that out. So schizophrenia for us is just under 20%. Affective disorders, Nick can help us, but it's very hard for me at any rate to figure out when you're chronically homeless and you've been in a 70-bed room at the Shepherd of Good Hope for the last 30 years, do you have an addiction? Was it an affective disorder that brought you there, and maybe you're managing that with alcohol or some other inappropriate way? Or you've been there for so long, you're bound to have an affective disorder of some form or another, anxiety or depression. And we have trouble sorting that out, but the rates are very, very high. And by the way, as it relates to addictions, alcohol, cigarettes are just about 100%. And we made no inroads in trying to prevent that, even though we've had all sorts of smoking programs. And we have our individuals who have concurrent disorders and we're challenging. And I'll deal with that in a minute. I just want to highlight this group. They're those with organic brain injury. As we develop programs to deal with some individuals with either alcohol addiction or other aspects of drug addiction or their mental health issues, most of them move on into either supportive housing for us or advanced programs with us. But there's some that don't. And we said, who are those people? They're always staying there. We can't move them. And they're generally 22-year-old, skidoo injury, when 10 or 14, behavioral problems, generally a mental health problem as well, and an addiction. There is just no place in our community that those people can go. They are either found in the lockups, in the hospital, or in our shelters, but there is no place. They can't go to a nursing home because they're 19, 20. They can't be close to your Aunt Zelda or something like that because they're going to be very disruptive. They can't go to a group home. The behaviors are too severe. And in the shelter environment, they get, very quickly taken advantage. So a very significant problem that we find is bigger and bigger. So we now just, I'll show you a number, just built another hotel, bought another hotel, and now we're going to buy another house. And the house that we hope will be for the acquired brain injury. Okay, last along this background is that what we tend to do is we take vulnerable populations, mental health, addictions, disability. We hive them off in unique areas of our community, lower Lower East Side of Vancouver, Lower Town for me. We deprive them of their usual entitlements because of their mental health and addiction, perhaps, and put them in settings of higher risk, a shelter, more trauma, more likely to addictions and other infections, etc. We're surprised they have terrible outcomes. Like, I wouldn't be surprised at that. I think that's exactly what you would anticipate. So, as a result, these individuals have a higher burden of disease, greater exposure, they lack resources for self-care, they have circumstances of mental illness and addiction, and there's a complex system of entitlements that's challenging for me as a provider. They're impossible for my clients. If you don't have an address or a telephone, how are you going to get to any of these services? You're ineligible for any of the services. You've got to have a drug card for some of these. Guys don't have drug cards. So let's very quickly tell you about what they told us. There's some obstacles that they said. These are the challenges for us: transportation, stigma, education. Their concept of health, which is crisis-driven, as you probably all well know, they tend to plan for long periods of time. Access to drug cards, medication, and how they feel judged on a regular basis. Those are the things that came out repeatedly to us when they said we want a different type of health service for us. And then I'll just go ahead very quickly. This is just to give you a sense of what we tried to do then, is how we actually brought services to them as opposed to forcing them into a system that didn't seem to fit them. And so we said, great, we will bring you an integrated service delivery model from primary care, prevention, all the way to treatment that will deal with physical illness and mental illness on your terms. So we said, right care, right place, right time. I'm just going to tell you very briefly what we do, and then you can question this. But it's mental health and addictions. It's other physical problems. We have a mixed alcohol program where we give alcoholics alcohol, try and get them off the alcohol as much as we can, reduce it as we can. But when we did that, stabilize the craziness of their lives, they all then said, we want to be on a place of our own, we want to be out of Lower Town, we want to have a dog, we want to cook, we want to have my own room. I want to be with my family, reconnect there, and I want to garden. And so we then bought the Oaks, it was the Cardinal Suites. They didn't like the name. They by then had a mayor, they thought it was too nice. And the mayor then said, Cardinal Suites. We wanted the Oaks. So it's now called the Oaks, and that's where they live, supportive housing on their terms. They have a garden, they have a dog, they have a euchre contest, which I constantly lose. They come up to my farm, where I live on a farm, and have Christmas trees for their Christmas party. They have a Halloween party, they have weekends with their families, they go to raise reptiles for outings and pizza nights. These are refractory alcoholics that were on the street alcoholics, being there for 30 years, failed by definition, had to have failed every treatment program available. And we would bring them in. Often they were drinking non-alcohol or alcohol substitutes and stabilize their addiction and then move them into a stable housing environment with support. They're still drinking about 1/9 of what they were drinking on the street. I wish they would stop. We keep bugging them to slow down. But for some, that's not their plan right now. And you have to respect that. So we said, okay, I would love you to stop, but if you're not going to stop, reduce the amount you can, and let's treat these other problems. But let's talk about stopping a little bit later on. So that's the managed alcohol program. We have a hospice for the dying homeless. We have settings where they can come up and down from the hospital. So we don't send people to the hospital much anymore. They just stay with us, and we provide IV, oxygen, all that treatment in the shelves. So very infrequently do our homeless population now go either to the emergency department or the hospital. We started off with about 30 beds, and we're now, the bed number is about 240. So with the size of a medium-sized hospital. We have an army of personal support workers, nurses, and nurse practitioners, and then myself. So it's a very heavily support side driven and not a very medicalized model. We use integrated case management aligned towards the goals of the patient. We ask each patient What are the priorities that you have for your health? What do you want to do about addiction? What do you want to do with mental health? How can we do that? What are the obstacles you have? And we revisit that monthly with every patient. And we build a system around their needs, not ours, their needs. We work with the criminal justice system, and I don't know about you, but we found that what we have to, as we start trying to deal with our challenge of addictions, to be successful, we had to start now branching out to the people around us, such as housing, such as the criminal justice system. More about community treatment orders or breach of probation than I would ever want to know. But what happens is we find that the criminal justice system sets individuals for failure, and they're happy to be partners with us if we're a drug order or the likes. But what you'll often see, and perhaps you see this as well, an individual, an alcoholic, disruptive on the street, the police are called, they sort of say, Fred, you can't keep doing this. Fred goes away, or they drive Fred away the next day. Fred's an alcoholic, he's drunk again, and he lives around that area, so it's not surprising he's back. Police are called again. Now they're getting mad, and the shop owner is really getting mad. He's called back again the next day, and now they're laying charges. As soon as the charges are laid, they're going to say, Fred, you've got to be in court in a month's time. Fred says, thank you very much. He's away. He's there again tomorrow, and he's forgotten about the charges. Now he's in breach. Now he's off to court. Now he's going to go to the detention center. It's going to happen again and again. Now they've barred him from that region. He lives there, and said, if you're drunk again, you're in breach again, you're going to jail for a longer time. Nobody's treating the guy's alcoholism. He's drunk again. Now he's in the provincial system. When he comes out of the provincial system, he's going to be drunk again, and he lives in this place. Now he's got a whole bunch of new skill sets. He learned a lot. He didn't get his alcoholism effectively treated in prison, and he's learned a lot of new skills that are going to help him acquire alcohol or whatever that might be. So I think we perpetuate the problem. So we have to think of new partners to help solve the problem. And lastly, I'd like to say that we've now had new providers, new roles. We've broken sort of just about every rule possible. Whoever can do what will do the what to make it work. And we'll figure ways around that. And I have to say, those people with lived experience for us have been probably the most valuable individuals on our team. They are fantastic. When I go and tell somebody, I think this should happen, they look at me and they say, right. When some of those people who are working with experience, who've been there, been successful in getting them out of that circumstance, they say that you've got to do this. They listen. So I've got to say that this has been a really important lesson for me. And then new partners, these are all of our partners that we work with on a regular basis. And just go through them on. And then we try and deal with those other things that are leading them to be sick in the first place. Housing, social support system, getting entitlements, getting them back in a stable environment, perhaps reunited with family. So those seem to be success factors in keeping them from going back to a life of addiction and back into the homeless environment. And then we set reasonable goals for them, goals that they've identified, not goals that we think would identify. And for those people who know Wendy Mucklow, she's the executive director who keeps telling me what to do all the time. She says, don't set them up for failure, Jim. Because what we do, and I do, is I have these expectations and I set people up for failure. We recognize that chronic illness. There will be times when people fail, and we need to be there to pick them up, not punish them. They're acutely sensitive to the judgment that they feel from others around them when they fail. And if you relapse in terms of your diabetes, nobody would mind. But for some reason, this is a characterological flaw. With a chronic disease, we actually get a worsening of your symptoms. And then we're part of a community that brings great joy to be a group of part of that community. Wonderful people, we have a great time, and probably the most enjoyable part of my day. So I'll stop at that, and others will probably be much more comfortable than I.
Thank you very much, Dr. Turnbull. Okay, what we'll do now, we're going to move to our panelists, and I'm going to ask each panelist to two questions. To start with the first one, to speak to the challenges that you recognize with addiction in our healthcare system. So if you'd like to just address that, and you each have, I'd say, about 3 to 5 minutes. Oops, sorry. Pardon? They can sit, I think we'll pass the mic. So who would like to go first? Steve? Steve, you're first. Okay, we'll just pass the mic along. So challenges.
I'm Steve Lowe, I'm a peer support worker with South Connection. I think some of the biggest challenges that I see is not enough paid peer support workers with the lived experience. I like to put it as boots on the ground. You need more people that have the lived experience. And what's the question that I get from participants that I've worked with in the last couple of years is, why couldn't I have found you sooner? Why couldn't I have found this 5 years ago? How come I don't know about you guys? So I think that's the other challenge is communication and education among the formal systems. I don't think that would be used enough as much as we can. I think that's a big challenge. I do deal with CPS and the justice system a lot. And I was just talking to a probation officer the other day who had said to me, she said, "You realize how many of my clients that you have?" And I said, "Or 2." She said, "No, you have 10." And she said, "How many probation officers do you work with?" I said, 5. So she said, "Let's think of how many people you're working with that I didn't even know were coming through." So I had mentioned to her is, well, why don't you set something up with Justice Department, probation, and parole officers so we could kind of tell you exactly what we do. And she kind of hemmed and hawed about it. Was kind of concerned about going to see her supervisor bringing this up. I was like, wow, that was something I would have jumped right on and said, that's a support in the community that is very vital. Some of the challenges that I see is people are, and I go back to the communication and use of the peer support workers is, in recovery, what I believe is people need to use every support available to them. So grab as many off the tree as you can, and then whittle it down to the ones that really work for you. And if you don't know that there's supports out there, you can't pick them all off the tree and use them to your advantage. Because we're all different, we all have different levels of recovery and different personalities. So what works for me might not work for you, but what works for you might work for somebody else. And that's the beauty of the recovery program is that lived experience of passing it on and getting it done. A big challenge that I see is, as Dr. Turnbull said, was the safe houses, the beds. There's not enough beds out there. I think there's 3 recovery homes at HRM, 2 for men, 1 for women. People are going into detoxes, and detoxing, that's just what they're doing. They're detoxing, not getting into any kind of recovery. Recovery takes time, it takes patience, and it's about changing habits and changing lifestyles. That's a lot of work, and you need a place that when you come out of there after 2 weeks, so dried out, you need a safe place that you could go for 6 months to a year and not have to worry about paying bills, just focusing on recovery and getting your life back together. And building relationships with your family and your friends and getting that stuff back, getting your morals and your self-esteem back, building yourself back up. That's a big challenge in recovery. So, safe places. When you leave these places, you need a place to go. And I do see a lot more youth coming into the office, and the sad thing is I ask them where they're staying, and they're usually sleeping on a friend's bed or on a friend's couch. Excuse me. They're sleeping on couches, and I said, "What's the lifestyle at the house like?" "Well, my friends out there and is smoking marijuana, drinking beer, loud music and stuff." I'm thinking, how can you recover in that environment? You can't. It's impossible. So that is a big challenge, finding safe places for people. When they walk out those doors, there should be a plan put in place that people are going to go to the establishment and have that safe feeling. So that's what I see. Thank you.
You're going to have to lift up your chair because the cord's wrapped around the chair and it won't stretch the whole way.
Okay.
There.
Good.
Get the chair up.
There will be time for questions after the panel also.
Hi, I'm Cindy with Direction 180, and thank you. There's a lot of great information. Challenges. so many, as it relates to serving and responding to the needs of people with addictions here in our community. For me, I see stigma at the root of the challenges, and I also see the lack of affordable housing. And the stigma, it permeates all of the systems, the provincial, the federal, the municipal, the funding dollars. And so, folk that have addictions are, they're not as sexy as children and babies and other health issues. And so, folk that are providing the services are always doing so with scant resources and in conditions that are quite often deplorable or ready to expire. And I think that speaks a lot when somebody steps forward and they want treatment in the environment in which the treatment is available, substandard. Also the lack of services that are open to the individual's autonomy and choice for what they want to address. I think for so long, services have been in, sort of institutional, tertiary type settings, and they have been designed, for example, a detox facility for somebody who uses multiple substances, and the crack cocaine is what is creating barriers for them because they smoke their rent check. And they're having abscess wounds, and it's creating unmanageability in their lives, but they're not ready to let go of the marijuana use, and they don't want to put down the cigarettes yet, and they're still going to use benzos. But the way our systems are set up is that once you enter into that facility, you have to address it all. And so I think we need more community-driven type facilities whereby people can go in and can present and begin to address just one piece at a time, if you will, and allow for that to happen in an environment that's friendly to them and supportive. Other challenges are the palliative care piece for people who are living in poverty. Healthcare. We have some phenomenal services here. We do. In Halifax, we have the Mobile Outreach Street Health, and some other great initiatives where we go out and we meet people where they're at. We're doing that with Direction 180, bringing the method onto the community where people live rather than having them travel daily. that's a policy thing that has to happen, and we have to get, it's the right people at the table to, agree, provincial formulary to cover the drug, and,
Naloxone? Sorry, I'm not.
Oh,
familiar.
naloxone is an antidote that will reverse an opiate overdose. And so it's something that you would provide to people who use opiates or other drugs they have it in their possession. If somebody were to show signs of an overdose, then you can administer it, and basically it's a bully. It boots the opiate off, and then allows for time to make other medical arrangements. So you save the life. The other thing I think in terms of action is increasing the amount of funding provided to people on income assistance would certainly help to improve the health, the quality of people's lives and give them more choice as to where they live, because people don't have much choice, and they're living in unsafe conditions, and shelters is not a home. Shelter is not a home, and we've had people here in Halifax living in shelters for 8 years or more, and that's not really because they like it, the shelter. It's because we don't have any alternatives. They might like the social piece, absolutely. Maybe they don't have anyone in their life, but they need a suitable, safe environment to live in. The other action is to stop making access or treatment to addiction so clandestine. So, if you prescribe methadone, having that information available on a website. Like if you need knee surgery, you know where to go. You can look it up, Google it, and find out who the surgeons are. If you're a prescriber or you're treating addictions, then that information needs to be available so those that need the help can access it. Because we're further stigmatizing the treatment by not stating that it's available and where you can get it. I guess, something that has to change. And, and I just think more resources. The way things are with the federal correctional system right now, I mean, they're tightening
Somebody has to address that.
I just want to say one thing before it skips my mind here is sometimes just catch up to the same. I think one of the big things that I was leaving out there is that I think education within the younger in the school system, I think is a big thing. Is that we really need to get into the three-tier school system, which would be the parents, the students, and the community, and the teachers themselves. Education addictions can begin in that elementary to junior high age, and I mean that's a real. The more education and more support systems we can put in there, we can get at it quicker and sooner and stop a lot of the destruction within our communities. So I think getting into the school system is a very big challenge.
I think some excellent work is happening in that regard here in Nova Scotia. There's a mental health addiction curriculum for the students in the schools, which would be great. So this is, we've had excellent presentations, here, and I'd very much like to invite questions and comments from those who are here. Now, I can reach this over maybe a little way.
There's a mic here, and then I can, why don't you put it under the table, Yeah. Okay, thank you. And we do have a mic here, so if anyone has questions.
Oh, yeah. Oh, yeah.
Okay.
Okay. Now, I know a person who went to a human resources education and training counselor. And the training counselor was very discriminating and prejudicial. And the person had had a neurological surgery performance. And the doctor that performed the surgery had wrote a note stating that there are no side effects, that the person is not on any medications, and everything is going well. And the employment and training counselor there said that the person would not be allowed to have a job that paid over $20,000 a year, and that they might even snap. Now, where is it that it says that it's the employment and training counselor's authority to judge somebody medically and say that they're going to snap? That is discriminative and that is prejudicial. That should not be allowed. And you guys are talking about addictions. Well, addictions come from a lot of things. And number one, have you ever watched a movie, a TV program? There's a lot of them there that every time you get mad, every time you had a hard day at work, first thing you do is go home, go into your study, grab the brandy bottle, and pour yourself a drink, chase the hard days away. And it's the same thing. You have a fight with your girlfriend. Many of the cops that you see on the TV movies, first thing they do is go and grab a 6-case of beer or something, and then they go to an isolated area and pour themselves drunk. It's brainwashing right on the television, right on the movies. Every day, it's pushed right into your face. The best way to cure it and chase your blues away is go and get yourself drunk. And then it's like, too, you guys are saying about the support houses and everything. We got enough condos going up here for the rich people, and we got the low-income housings. So why can't you guys and the governments get together and start having like an apartment complex for the people with the addictions? And then they don't feel like they're judged by their neighbors because their neighbors are the ones that are sober. The neighbors are the ones that are so much better because they're on the upper class scale. The neighbors are going to be the same people that they are. That way they feel equal. They're not being judged. And then they both have them to rely upon through times of crisis. And also at the same time, you guys could have like a counselor there that could be, in case there was an emotional crisis or an addiction crisis, and they could talk the person through it. There's a lot of things that can be done, and I'm just touching base.
Okay, thank you. Very good. You touched on the problem of stigma which Dr. Mills had mentioned, stigma within the system. You know, there is a great deal of stigma against addictions and mental illness within the healthcare system itself. So that is huge. Problem with housing is another big area. I'm going to ask people to use that mic rather than be right up here. I don't think we need to have two mics, so I'll pass it back to you. So would someone like to comment on Patty's issues with the stigma?
It's true.
It is the truth.
Dr. Delva says it's the truth.
It's the truth in general, and it's the truth within the medical profession. And it'll take a little time to eradicate it. I think Steve Ayer, the CEO and executive director of the Schizophrenia Society, would like to say something, ask a question.
Yeah, I have a question for Dr. Turnbull. Wonderful work you're doing in Ottawa. My question would be, how is all this wonderful work funded?
That's a really good question. So it began with, and it's an interesting story too. So it began with an HRDC grant that I put in with some of our colleagues. The whole process began when we all sat around in a room and just got together and just said, you know, we're doing a terrible job for this population and we could do so much better. And then we said, okay, well, let's put in a grant. And we'll get HRDC funding for a pilot project that provides care, as I described, out in the community on their terms. And HRDC said, fine, but you have to have a formal evaluation, both economic and effectiveness evaluation, externally. So we said, fine, we'll do that. Then we did, and showed that we saved $3.5 million at that point in time. We were a lot smaller, net of our expenses. And all of our outcomes in terms of self-care, treatment of addictions, etc., were better. So then we just went to the Ministry of Health and said, great, you know, bring it on. We're, you know, pay for us now because we're saving you money and we're getting better outcomes. They said no. They said that this is a social services problem. Go to social services.
Yeah.
So for funding. So we did, and they said, no, that's not a social services problem. You better go to housing, and they'll be the ones who'll solve the problem for you. And then housing, of course, said go and see health because that's how that works. So we began that way, and then we ran out of money. Ran right out of money. We were going to close within a week, and we had about 60 people in the program, or 70 people, and we said, fine, we'll call together a goodbye party, and we'll invite the press. We'll have politicians there, the mayor, chief of police, and CEOs of all of the hospitals, because they're going to inherit in the emergency department all of these people tomorrow. But feel free, you know, members of parliament come, and we invited the Minister of Health as well. And that day, we got an announcement that we were fully funded. Everything but the doctor. So the doctor was not paid, but everybody else was paid for it. So now we're funded by the Ministry of Health, and we have some additional funding coming from the municipality because they've asked us to do additional things. So it's a bit of a mixture of different sources of funding, but primarily it's all from the Ministry of Health because frankly we save them the most amount of money.
Could I ask what kind of money you're talking to initially start out? What did you ask for? What was your ask?
$1.3 million was our initial HRDC grant. Our operating expenses now for 240 beds, personal support worker, about 100 personal support workers, 7 or 8 nurses, 2 nurse practitioners,
individual, I think would speak volumes, but the likelihood of me getting that opportunity is not gonna happen anytime soon, so.
I don't think I have anything else to add. I think it's all been said.
Good, thank you. Barb?
Hughes, mental health coalition, Dalhousie University. Really like all of your comments, they've been very helpful. I'm just wondering, housing first. We're about to embark on housing first in HRF. Please, we are. And just wondering, does your Ottawa initiative fit within the Housing First model? Is it part of the Housing First initiative in Ottawa? And what you're also talking about, that everybody's talking about the silos. The silos, one of the biggest challenges within Nova Scotia is not only that there's a silo, but they're competing for resources. So if I get them, you don't. And so why should we work together? Because I'm in competition with you for the resources. So all of that. And I know that Calgary has found a model to have the umbrella resources available to everybody. So that's really interesting. Just wondering if you have some thoughts as Halifax prepares for Housing First. We've got partners of, I think, 8 large partners coming together to figure out how to go about this. If you had some, as you look back on reflections about if you were to do nothing else, your first step should be, it would be to know, as we embark on this initiative, what should we be looking at? Because I think this is our one opportunity to really engage in having everybody working together and looking at the whole rather than the parts.
So housing first, I think I think everybody would say, and this is an essential part of it. It surprises me a bit that people are not so just housing first, because that's been around for a long, long time. Housing itself, just a house, I think nobody would think that that's what you want to do. I think you want supportive housing. So that would be the challenge of having in a context of a housed environment, wrapping around supportive systems to ensure that's set up for success. So how do you do that in a siloed system when we need an integrated programmatic system where everybody's working together, aligned to the direction of success? And to do that, they have to be resourced appropriately, and they have to be aligned and measured and accountable for the same outcome. Those are things we don't do now, so I would think if we could move to a programmatic management structure where in a housed environment we say housing first, yes, supportive housing, definitely, and thinking of an integrated governance model where everybody is working together for the success of that particular client. I think that when we get to that step, those are, I think, the things that we need to be promoting. And yes, we do take advantage of housing first. That's what the model that we're using, and our 2 buildings, one with the John Howard Society for mental health and addictions, and the other, the Oaks that you saw there, are all built around wraparound services. So we have everybody coming and supporting individuals on their terms, their objectives. That would be my comments, but I'm sure everybody would think strongly about housing first too.
Hi, my name is Paul Surratt. I'm a counselor and I'm a training coach with specialization in ADHD. Dr. Mills raised a point earlier that I wanted to address, and that's with regards to the workers with mental health and addictions, and especially within capital health and the health districts throughout the province. And the fact that now they're developing programs to give them instruction on awareness around addictions and the comorbid symptoms and everything that goes along with that package. As good as that is, I really think there's an opportunity that's being missed because there are, I know many counselors who are taking programs that are available out there, and these are people who have life experience, who have lived experience, and the reason they're getting into this program is because they have that experience and they want to help others who are there. Unfortunately, with the makeup with capital health and so on, there's a restriction there, and I think that capital health and the other health districts in the area are really missing out on a plethora of information and helping people who are really motivated, because as good as
critical a situation it is moving out into the rural areas now. So that's just my question to you.
It's a great question. It's a huge problem, and no, Ontario has not solved that problem. We know the prevalence of mental health and complex addictions in the rural settings is actually higher, and the treatment delivery systems out there are less. So as a result, people in rural settings suffer disproportionately. We should have a hub and spoke type model out into the rural settings where we have access to reasonable housing and addiction services. But when you go to small communities and you try and look at methadone, for example, that's not going to exist in a small community. If you're going to be on methadone, you're going to have to come into Ottawa for that. You won't get that in Pembroke or Arnprior, someplace like that. It's a big problem in Ontario, just like it is by the sounds of it here.
Yeah. And out here, I think too, in the rural areas, I would have to say marijuana is actually becoming the new cigarette. I think people are actually youth, and I'm agreeing with you. It starts in elementary and junior high, and then just escalates from there. But I would say there's more use of marijuana particularly in the rural areas. And I'm not sure in the central areas, but probably more use of marijuana than cigarettes.
Okay, thank you, Martha. Martha, go ahead. No problem.
I wasn't going to say anything, but I need to piggyback. I'm emotional about this, about Pat's comment. As I've listened, I hear that it's politics, the government. We don't have enough money. We live in silos. We're competitive. We don't want to share. The professionals have spent a lot of time and money getting their training, being told that they're experts at what they do, and on some level they are. I think Patty has said something really important, whether it's addictions or mental illness. We're treating the symptoms, and while we continue to treat the systems like rats in the maze, we're going to continue the cycles until we start dealing with the real core, which is self-worth, or low self-esteem, or lack of love, or whatever term you want to use for that. We're going to continue to be in the mess that we're in. And I don't have a PhD, I don't even have my master's. I'm 61 years young. I'm going to use the word transformed my experience with my addiction and mental illness. And until we teach people that they're not their behaviors, that we've learned these behaviors, all of us, in response to whatever has happened in life, that's where the hope lies. If I've learned a set of behaviors that have hurt me, then I can also learn another set of behaviors that will help me. But I need compassion. I need a home to live in, all the things that you're addressing. Those are, the basic, the hierarchy of needs. And until we help people get these basic needs met, they can't help themselves. We can't expect them to do something. So we're really setting folks up for failure. And that has to stop. And I'm filled with some hope today. I think that the peer support and an opportunity for one person to take the hand of another person and reach out and help. I heard you speak last night and again today. The passion, that you have for what you do. And I think many professionals in our system once had that passion, and they've lost touch with some of it. The same way those of us who have been mentally ill or struggling with addiction also get lost, in our journey. And I wish there were more people here today because the folks who are here today already know this message. Our work is really about getting out there and talking to the folks that need to hear what we have to say.
Well, I think that's a great last word. I think our visiting professor in medical citizenship really embodies passion and compassion. And obviously, Dr. Turnbull is being extremely creative in terms of harnessing that passion and compassion, and that's what medical citizenship really is all about. So I think we've all had a great insight into how that compassion and passion can be put into action, and I think we all endeavor to be better medical citizens or better citizens overall, and that's obviously at all kinds of different levels, from the political to the very day-to-day lives that we live. We've heard a lot of suggestions about how we can move forward, and I'd like to thank all of you and all of our panelists and our visiting speaker. The Visiting Professorship in Medical Citizenship is the underlying sponsor for this whole endeavor, and it's a very valuable yearly event. And today we've been focusing on addictions. Thank you very much, Dr. Turnbull. Thank you, panelists. Thank you, audience.
I would like to invite people, we do have more time here, to invite people to stay for a few minutes. There's tea and coffee and water over on this side, and some muffins. So if you'd like to, the panelists are going to be here for a little bit, so if you have some individual questions, you can also speak with them. But thank you for coming out, and hope to see you next year. Thank you, panelists.